Good evening, everybody. Welcome to yet another episode and yet another session of the CCI webinar. It has been over 2 years that we have been doing the webinar, and we have managed to not repeat a single topic. And every time we come up with interesting topics, thanks to the CCI core committee, who really put in a lot of effort to come up with newer topics. And today we are actually talking about role of Paxlovid and booster dose in the current outbreak of COVID. So we all know that the COVID cases are rising. We have a very, very esteemed panel of extremely senior and learned people with us, and I will be very, very happy for to interact with them so that they can put forth their views on certain questions and certain issues that we need clarity on. So to begin with, I would like to introduce the panel. Most of them actually need no introduction, but however, it is my job to introduce all of them. So first and foremost, Dr. Rakesh Chawla, sir. Sir is again a stalwart in pulmonology. Sir is Chairman and Senior Consultant, Department of Respiratory Medicine, Critical Care, Sleep Medicine, Interventional Pulmonology at Saroj Super Speciality Hospital in New Delhi and Jaipur Golden Hospital in New Delhi, and also the Rajiv Gandhi Cancer Institute. Sir is one of those people who are very, very well known in the field of interventional pulmonology especially. He does a lot of conferences. He is an internationally acclaimed person, needs no introduction. Next is Dr. Pratibha Singhal ma'am. Ma'am is again a stalwart who needs no introduction, is extremely talented, is very active in interventional pulmonology, is one of those few people who has had the opportunity to be the secretary of the interventional pulmonology wing of the ERS, if I'm not wrong. Ma'am is currently attached with the Bombay Hospital and also the HN Reliance Hospital in Bombay. So thank you, ma'am, for agreeing to be on the panel. Then Dr. Niranjan Prabhakar. Dr. Niranjan Prabhakar, welcome. For Dr. Niranjan, this is the debut webinar. Dr. Niranjan is one of the young brains we have with us today. He is a MD and DNB pulmonology and currently practicing in Madurai, Tamil Nadu. Then we have Dr. Ramesh Bharate, sir, again, extremely senior person. Sir is currently working at Latur, is a senior professor, extremely experienced, has various accolades to his own credit and needs no introduction. Then we have Dr. Hirennappa Udnur, sir. Dr. Udnur, sir, is currently practicing in Bangalore. He is a senior consultant in pulmonology, a very senior name in the field of pulmonology, and needs no introduction. So for the flow of the program, we are going to begin with a small presentation, after which we go to the panel discussion. During the panel discussion, we will also be taking questions from the audience. So we are talking about the newer strategies in COVID-19, given the recent surge in cases and how the cases are actually spiking again. And I think especially in people who have comorbidities, sometimes it is getting to a serious level, and they're coming with severe disease to a lot of us. They're getting admitted, they're getting ventilated. And after March 22, especially in India, there have been no new guidelines which has come out. Of course, in between, there have been a lot of developments, like Paxlovid is there in the, not yet there in the Indian market, but it is there in the market. A lot of countries have started the second dose of vaccination, of booster dose of vaccination, which of course in India, we still do not have a guideline on. And certain other things like, you know, the 3-day introduction of remdesivir, which came much before, which we haven't really discussed. So I think these are things that we thought we would discuss. And I'm going to just briefly touch upon certain aspects of this, and then we will go into the details in the panel discussion. So the most common variant or the subvariant of Omicron today, which is prevalent in India, is BA.5, but in other countries, a lot of other countries, even BA.4 is pretty much prevalent. When we talk about the immunity that is conferred to COVID over the years, we've seen is basically there are two important things. One is the antibodies and the other is the cellular immunity. When we talk of antibodies, I think the first mechanism of defense which we have is the antibodies, which are the IgA and the IgG. IgA, which is more prevalent in the nasal mucosa, and IgG, which is of course more prevalent in the bloodstream, and are basically these antibodies which evade and neutralize the virus when it enters the body, and sometimes it presents in terms of maybe just a mild cough or cold or coryza, and that's where we are basically getting infected with the virus and the antibody is trying to fight it. The other is certainly the cellular immunity, whether it is the T cell or the B cell immunity, which is practically conferred either by prior infection or vaccination. So both these cases, we get some amount of cellular immunity. How long it lasts, it's something that we still do not have specific answers to. But when we talk about antibodies, we do all these tests when we're doing the testing and measuring the spike protein antigen, but we do not know how important it is, what is the final conclusion that we draw of it, how much importance do we give to it. It is still very unclear how the antibodies persist following either infection or vaccination and for how long. There are certain cases wherein the antibodies persist for almost 14 months, and there are certain cases, especially given the current subvariants, wherein the antibodies do not persist for that long, and hence the reinfection rate is pretty high. Also, getting a negative serological test does not preclude prior COVID infection or vaccination in either case. There are certain people who have been infected with COVID and or have been completely vaccinated against COVID, but they do not still have measurable antibodies, and these are especially patients who may be immunocompromised. Currently, whatever vaccines are available in the market do not contain nucleocapsid proteins. Hence, we need to have serological tests that detect antibodies by recognizing nucleocapsid proteins, and hence then we would be able to differentiate between the antibody responses to natural infection or vaccine-induced antibody responses to the COVID antigens. So where do we stand with these serological tests? What is the point of doing these serological tests? Of course, to determine if somebody is eligible to donate the convalescent plasma. Having said that, convalescent plasma is pretty much not in the guidelines anymore, is not a recommendation. Or else it defines multisystem inflammatory syndrome in either children or even adults. Also, it estimates the proportion of the population that has been exposed to the COVID virus. Then coming to remdesivir, which is an excellent drug. We've all used it all across, all through COVID. Is very good because it can even be used in pediatric patients over 27 days of age and or over 3 kgs of weight. In high-risk, non-hospitalized patients, there was a recommendation to use it even in patients with mild to moderate COVID-19, wherein they have a risk factor of developing a severe disease. It can be started within 7 days of symptom onset and then administered for 3 days. These are patients who can walk into the OPD, into the daycare, get their shot of remdesivir and go back home. They don't need to be admitted. Whereas people who have been hospitalized for whatever reason should receive remdesivir for 5 days or until discharge from the hospital, whichever is earlier. So this is about remdesivir. We can even use it for 3 days. Pretty acceptable, pretty much in the guidelines, and something that we should be looking at. And then there is Paxlovid, which is actually not one drug, but a combination of 2 drugs, which is nirmatrelvir and ritonavir. The indication is in mild to moderate COVID infection in people who are at a high risk for progression to severe infection, including hospitalization or death. It can be given in children over 12 years of age or over 40 kgs of weight. The mechanism is simple. Nirmatrelvir is a SARS-CoV-2 main protease inhibitor. It inhibits viral replication in the early stages of the disease to prevent progression to severe COVID. And then there is ritonavir, which is co-administered which only helps to slow the metabolism of nirmatrelvir in order for it to be remaining active in the body for a longer period and at a higher concentration to help combat the virus in a better way. The dosage, there are two drugs. So 300 mg, which is 2 tablets of 150 mg each of nirmatrelvir with a 100 mg tablet of ritonavir. That makes it 3 tablets. 3 tablets to be taken in the morning, 3 in the evening. So 3 tablets twice a day each for at least a duration of 5 days. But there is a dose reduction recommended for people with renal impairment, especially with GFR between 30 to 60 ml per minute. The tablet for nirmatrelvir is reduced from 2 tablets, that is 300 mg to 150 mg, from 2 tablets to 1 tablet, and the dose of ritonavir remains the same. So that means that 2 tablets to be taken in the morning and 2 in the evening for 5 days again. There are certain contraindications like severe renal dysfunction, hepatic impairment is a contraindication. Pregnancy, you have to weigh the risk to benefit ratio and then take a call. In kids less than 12 years, absolute contraindication. Again, this is one drug which has a lot of drug interactions, but then we are only giving it for 5 days. So again, you have to weigh the risk to benefit ratio. Has a lot of drug interactions, especially with anti-tubercular, anti-HIV drugs, with anti-epileptics, and a lot more. There is a long list which is practically available on the internet. There was this landmark study done in fact for Paxlovid, which is the EPIC-HR, which basically is evaluation of protease inhibitors in COVID-19 in high-risk individuals. This was a multinational randomized trial, which was a double-blind 2-arm study. One arm was, of course, Paxlovid, the other was a placebo. There were over 2,000, that is 2,246 patients who were randomized depending on the eligibility. The eligible patients were randomized within 5 days of symptom onset and were either non-vaccinated or had at least one risk factor for progression to severe disease. These patients were excluded if they were using any medications or they were highly dependent upon medications which had, either for clearance or strong inducers of cytochrome P3A4 because of the drug interactions. The mean age of patients that were enrolled was 46 years. 51% of these patients were men and almost 72% of these patients were white. 47% of these patients tested negative for COVID antibodies and 66% started study treatment within 3 days of onset of symptoms. So there were these 1,379, so almost 1,400 patients who were randomized within the 3 days of symptom onset. Their COVID-19 related hospitalization or all-cause deaths occurred by day 28 in around 0.72% in the Paxlovid arm and in 6.5% in the placebo arm. Among the 2,085 patients who were randomized again within the 5 days of symptom onset, COVID-19 related hospitalization and deaths occurred in 8 of the 1,039, which is 0.77% in the Paxlovid arm and 6.3% in the placebo arm. Given the p-value, it's a very, very significant difference. And of course, there were no deaths in the Paxlovid arm and 13 deaths in the placebo arm. The results look very, very promising, but in June, there were multiple reports, stating that patients initially, of course, after use had, they were better and their COVID test came negative, but they eventually had rebound of symptoms. But also there were reports that there is a high incidence of the virus mutating and then becoming resistant to Paxlovid. Now the concern is that once we start using it and use it in huge numbers, maybe then it may become resistant, but that's actually a problem for another day. So far in India, it is not yet available, so I'm not sure where we stand. And once we start using it, we will maybe, face our own problems and maybe eventually also face resistance. So that's all that I had to say about the the recent advances. Of course, we are going to have a much detailed panel discussion with the esteemed faculty, and wherein we will also answer questions which will be put up by you all. Thank you. We'll move on to the panel discussion now, and we will also concomitantly, simultaneously take questions from the audience. So to begin the panel discussion, I would first like to move to Pratibha, madam. Ma'am, I want to ask you, so given the current scenario when so many people have actually been exposed, and I'm sure a lot of people come to you with, common cold-like symptoms or just cold and cough and maybe fever for 2-3 days. So when exactly are you ordering the COVID-19 test, or are you ordering the test for everybody?
Thank you, first of all, CCI, for involving me in this panel discussion. And very relevant question, Shivani. I think, currently in the present scenario, not just COVID, there is so much of other viral illnesses around that almost every other person is down with flu-like symptom. So I think even the guidelines that are mentioning that basically our aim still is to try and isolate patients who are positive, and secondly is to identify high risk people who are positive, who have a risk of progressing to severe disease, right? So people who are more than 60 years old, people who have concomitant diabetes, hypertension, chronic kidney lung disease or malignancy, or other who are on immunosuppressive agents. So I think at this point in time, the general population at large who are at low risk for disease progression are themselves not very keen to get themselves tested, and currently it is a reasonably self-limiting flu-like disease in these patients. So one would not advise random COVID testing in everybody who has a flu-like symptom, but more so in patients who you are suspecting could, if they have COVID, then they have a high risk of progression, you would want to identify them early and isolate them and keep a closer watch on them. So that is what even the ICMR is recommending. Of course, in the other scenario is that when you're looking at people who are exposed to people who are diagnosed COVID-19. So in that, the people who are not at high risk, again, you would not want to do the COVID test, but in patients who are at high risk and they are in contact with the COVID-19 patient, you may want to do the test and see, because in case there is any symptom and they need admission, sometimes it becomes difficult to get them into a hospital care facility without a COVID test. Especially in the private setup, sometimes you find it difficult because hospitals don't have clear-cut segregation of, earlier we had a interim area where, we were COVID suspects, but now with non-COVID cases on the rise, now COVID suspect areas have gone, and now we just have COVID negative and COVID positive areas in most hospitals. So in that scenario, you may want to do a COVID test and keep the patient under monitoring. And of course, now there are very clear guidelines even for hospital-based setup, which though in the private sector, and it's not always easy to follow. I know most hospitals still ask for COVID tests before admissions and before procedures, but actually if you look at the guidelines by the center, it is not recommended anymore in patients who don't have symptoms to suggest a COVID positive status. So I hope that summarizes your question and answer. My answer is going to help the people who have joined in this meeting.
Absolutely relevant and practical response, ma'am. I think that's what we are also doing, that we are only doing it in people who are either having comorbidities or people who are having comorbidities and are exposed to COVID-19 patients, because most of the private hospitals, like you mentioned, have actually stopped the isolation or the interim ward system for now, at least. So absolutely. So moving to the next question to Chawla, sir. Sir, do you think in the current scenario, there is a role of these home testing kits, which are very easily available over the counter?
Let me add to your first question. Whatever Pratibha and you have said, you have to be practical. When a patient in this scenario, when you are getting a flu-like symptoms, which are mimicking the COVID symptoms, and sudden onset of fever, if patient has sudden onset of fever, severe myalgic pains, and then he has got the irritation, cough, if you mix up with the flu-like symptoms, to admit him in the hospital without doing a COVID test, it is absolutely wrong. It has to be done. Reason being, COVID, you do not know how it will behave in a comorbid patients or in a fresh patient. You still do not know how, in which patient it is going to go into the storm, or it is going to be like a mild flu-like symptom. Abhi bhi, you have to be, this disease is a disease of fear. And this disease is a second week disease, because patient is coming with symptoms. Definitely he has an incubation, already 3 days are over. And by the time he reports you, 3 days more are over. He may be entering, you do not know about it. Doing COVID testing, either with the rapid antigen, I'm going to answer your question. RT-PCR, which is universal in the country, is 300 rupees. I am sure you are not a loser by doing COVID RT-PCR. You gain by doing it. Patient gets reassured. You also get reassured. You have hesitation to put him in the place, and you have no hesitation to visit him even in the ward. Speak or don't speak. Still, if the patient is a COVID, everyone has got an hesitation to go and visit that patient if the patient is stable. Now, coming to your second question of the home testing, right? This, we know the basic principle of COVID is you test, you trace, you treat, and diagnose in time. These rapid antigen test kits basically were developed for mass screening. When you're getting down at the airport, immediately they are doing the rapid testing. Now, the problem is the sensitivity and specificity is around 30-35%. Rapid antigen negative does not mean the patient is negative. But if it is positive, it is true positive. The drawback of this rapid antigen test kit is, since it is handy, it is very easy. It will be detecting the viral nucleocapsid protein in nasopharyngeal and oral secretions, which you are doing a testing and you are putting into the VTM, and you are putting that drop and seeing the lines of the control and the line of the positive test. Now, if the one member of the family is positive, rest are not doing it. And nobody is uploading this data on the ICMR portal. So you do not know the true positive patients in the community, even if it is a 30-35% positive. People have taken it so lightly because the symptoms are resolving 4 to 5 days. They are not at all going in for testing. And if I have a perception there is no use of doing a COVID testing, so I add on to the system. So the drawback of this is, since it is sold over the counter, you are not able to put it on ICMR data. You do not know the true positive. The whole family is positive. You don't have any data of that family. Nobody is stopping work. Nobody is going in isolation. Everybody is taking the Dolo or the paracetamol and taking the Montelukast, and he is going on work because the fever is subsiding. On the way, how many people they are infecting, still we do not know. We say it is confusing with H1N1. Okay, this is an excuse. H1N1 and COVID, two different entities, totally different entities. Only human to human, if there is a spread, that is of the COVID. But H1N1, well, the larger droplets, people are using masks, people have taken away, now thrown away the mask, COVID appropriate behavior has disappeared. So you need to be careful. I think even if they are available, people are doing, at least doing and seeing positive, they should stay home. They should follow COVID appropriate behavior. They should take care of their family members. And if possible, there are instructions on these antigen kits to put the data on the ICMR portal, which is not difficult. So that will reflect true positive. What we are getting, the Delhi's positivity is now less than 10%. 1,600 has come positive. They may be much more than that. Thank you.
Absolutely correct, sir. And I think since you are in Delhi, I'm sure you must be seeing a lot of these patients. So since we are already getting questions from the audience, which I will take subsequently, my next question I would like to ask Dr. Niranjan. So Dr. Niranjan, since I was talking about the, RT-PCR, so all during COVID, right from the first wave, we kept hearing about CBNAT and RT-PCR. What is your take on both these tests, and where do you think we stand in terms of both these tests?
I would like to thank everyone for this opportunity and start this. Actually, RT-PCR we have been using starting from the first wave. RT-PCR is considered as the gold standard for testing this COVID-19, and RT-PCR it takes some time actually. While this nucleic acid amplification, CBNet and TrueNet, they come in a very shorter period. We get the result. That is one big advantage with the CBNet. One practical issue which most of us felt during the CBNet usage was while we tried to use the all the CBNet was used for COVID and we did not have cartridges to test for TB. That is one practical issue which we faced during that time. And RT-PCR being the gold standard, it checks the genetic material of COVID virus, and with that we come to the decision. Comparatively, I feel RT-PCR should be considered more strongly and recommended compared to the CBNet. Sensitivity of RT-PCR is also comparatively more.
Absolutely, absolutely. So I
I
think
would like to add a thing that this cycle threshold during this RT-PCR that will also give you an value about the viral load. That will be of good use while treating the patient who has high load and who has low load, that we can make out.
okay. Do you think it will, the viral load will dictate how you manage the patient?
No, madam. Actually, it does not directly tell how it manages, but I feel that when the cycle threshold is very less, the chance they spread is more. So we should isolate them very quickly. That's what we can confer, I feel.
Right. Okay, great. Thank you. So, in between, can I just take a few questions from the audience so they don't go pile up? So, there's Dr. Prasanna from Bangalore who wants to know if there is any role of oseltamivir in mild COVID positive or influenza-like illness. Dr. Bharate sir, would you like to answer this, please?
Madam, can you repeat the question?
Is there any role of oseltamivir in mild COVID positive or influenza-like illness?
Oseltamivir is preferably used in the swine flu, and COVID is a different entity. But as far as up till now the study which are available, there is no role of oseltamivir for the treatment of these COVID-19 cases.
Right, absolutely. And I think only to add, I think mild COVID positive patients, if they do not have any comorbidities, don't really need a lot of aggressive treatment per se, other than just symptomatic treatment. Now, there's another question from Dr. Prasanna. Dr. Udnur sir, can you please answer this? He wants to know if there is any lung involvement in the current surge versus the previous waveform. What is the difference in terms of lung involvement?
Definitely lungs are involved, but we are seeing it is not directly proportional whether all COVID can infect lungs. That is definitely sure. The present scenario, we are seeing less number of patients, but the serious illness definitely do exist because of the availability of the bed. Some hospitals are saying we are not taking COVID and all. We are still seeing COVID. We are still seeing COVID-like picture with ground glassing, sometimes crazy wave appearance. All this lung involvement is definitely is there. But the now present strain, whatever it is causing, we are getting 2 to 3 days of fever, and it will subside. As Dr. Sir said, it rarely goes to second week or third week. Very few patients for unvaccinated or a comorbid patients, and these patients are 6th or 7th day. Earlier in Delta, we used to have 4th or 5th day only the lung presentation of ground glassing appearance was 3rd or 4th day of CT only would have got a GGO. Now it takes a longer time. Maybe that's the thing which we have seen. But lung involvement, COVID is a disease starts with the nose and sneezing symptoms and systemic symptoms. All those symptoms are still seen, but definitely late. It is a slow involvement, unlike the Delta. That's what I have seen.
Absolutely, absolutely. I think absolutely valid point that we are not seeing a lot of lung involvement, although a lot of patients come with chronic persistent cough, but it is mostly upper respiratory tract which is involved in the current
strain. Yeah.
Even in this current scenario, patients are presenting with GI symptoms and they are COVID positive. They don't have any lung involvement. They don't have an upper respiratory infections. They have abdominal symptoms, loose motions, pain abdomen. Doing COVID is coming positive, right? So that's a difference in this wave. You are getting less severe respiratory symptoms than the Delta type.
Right. Absolutely, yeah. Less severe respiratory symptoms and less requirement for higher oxygen. Even if it is oxygen, it is at much lesser levels. And usually with people who have comorbid lung disease, they're just getting a mild...
unvaccinated, non-vaccinated.
Yes, non-vaccinated, yes.
Yeah.
Right, sure. So I'll go back to questions from us and then in some time maybe subsequently take questions from the audience as well. Udnur sir, I'll ask you again. So we've been talking about, the current wave and how the testing happens. So initially when COVID started, there was a lot of hue and cry about surveillance testing, people who were traveling from one city to the other, people who were exposed, everybody had to be tested. I know of certain hospitals which was actually even testing people who wanted to go and see a patient who was non-COVID or was admitted for some elective procedure. So where do you think we stand with the surveillance testing today, especially now that the international borders are all open?
I feel it is better now. And it is good. And international travel also, people are not testing. There are country-specific guidelines. They want some RT-PCR mandatory reports, and nobody is asking for that mandatory things, and those things have gone off. And active surveillance, when the patient is sick and somebody reports it to a portal, to a BBMP portal or those portal, their numbers will be registered and they screen actively for all the members of the house, and sometimes the apartment is locked down. Those kind of system is not there. The active surveillance among the community to the guidelines from the government institute or those things, that's not happening. That is less. In terms of patient, individual club of patients, a family member who comes to a doctor who has other symptoms, then we see the patients. If a young fellow is admitted, he may not require a COVID test, but he has a COVID-like symptom. And if he has a parent who are 80-year-old, then they can be infective. That time we tell them, you test them and don't infect them. And because we are bothered about those people, and they do those kind of surveillance. As such, the surveillance is required at this point of time, because the way the R2 changes when there was a mix of COVID infection, there was people were asking whether it is a Delta, whether the people has returned from UK strain is very dangerous. Like people are asking, is it Delta? Is it Omicron? This will not work for the certain drugs will not work for Omicron. Certain drugs will work for Delta. So I should not have Delta. It is okay to have Omicron. These things were going on initially, but these require proper labs to which they can do a genome sequencing. Normally they send it for genome sequencing. To get that report only used to take a lot of time. So we are bothered about only RT-PCR, whether it is COVID or not. Subset or subvariant like BA1, BA4. It is only for community at large. If there is a pattern change, sudden surge of new numbers, because we are not seeing in TV channels that these numbers are increasing, deaths are increasing, like that surveillance is not happening. And the surveillance, whatever is happening, they have taken it for certain subset, because certain country, and they have seen that epidemiological inputs are given from WHO, and this country strain, a new strain is going to become a more havoc, like South Africa. It started Omicron like that. Those kind of surveillance, like a passive surveillance, when they have done a RT-PCR, certain subset of patients, certain international these things, when they do a genome sequencing, that will help for epidemiological purpose, and that can help in making a guideline. And certain times, certain drugs which they are changing, which will change the management, those things are helpful in making a framework of guidelines. As such, there is no strict, because even our life gets screwed by having more and more surveillance, because every day we are going to hospitals. Now schools are not asking, somebody is having fever, even kids tell that you have fever, take rest and come back. I think this should be okay, and we should have an isolation place, because hospital has a patients who have all kinds of patients. They should have a COVID testing mandatory there, and we should have a COVID negative, COVID positive ward. That is okay. In community, definitely people are using masks in people who are aware. Over a period of time, it is very difficult to maintain with this kind of isolation system, and things will prevail and it will slowly efface. And now it might be a situation where you have a viral flu-like syndrome. It can be COVID, flu, it can be anything. We are doing a more of respiratory panel testing. Means you have 3 or 4 virus kit. You do that and then rule that out and find out whether it is a COVID, flu and all. Flu has specific medications. H1N1 has a specific anti-flu. We can give that. Now there is a mixture of flu and COVID going on. Sometimes we get both as positive in certain situations. This time it was flu suddenly surged up because most of the patients are not vaccinated for flu and vaccinated for COVID. And sometimes it is difficult, and flu has an international surveillance to have a better vaccine every year with the new strains or 4-3 strains. Like that only COVID in terms of vaccination preparation or a future strains, and because if it is changing its color and this thing, it might help in vaccination. That's why surveillance is required at large. But
Yeah.
as at clinical level, probably it may not.
True.
Dr. Hirenya, as the surveillance has gone down, government started talking about genome sequencing to identify the different strains in the community.
Yes.
But the liberty the public has taken, at the same time, once I have removed the testing in interstate and intrastate and international, I have taken away the mask also, COVID appropriate behavior also, which is not followed at all. So problem in the public is you give little to them and they want to take away everything. And that is the problem, that even patients are not wearing masks. The doctors are not wearing masks. All of us have taken it for granted. This is where the...
Sir, it has become problem because it should be, I mean, in moderation. Very strict lockdown and strict usage of masks, strict gloves, strict PPE kit. It's not. A simple mask, even in the wards, we are going with the mask, N95 mask now. Earlier, we are not going with the PPE kit. So, simple mask, too much of aggression in terms of spreading the disease, and that will actually, it will make our life also tough and general public's life tough. Sometimes patients come with some flu-like symptoms. We think that we are honest enough to do a COVID test. It will, we have to prevent the public spread and all. We write COVID, they get annoyed. So I am young, I don't have comorbidity, you don't have to test me, I will take rest, they will tell. Sometimes we don't do by voluntarily, by volition. Doctor didn't even diagnose it. He said it is flu, it will go. But I deteriorated. So it is very tricky at the end of the patient. For doctors are ultimately even not testing will made a prey, and testing is also, they will blame the doctors. So you should choose the patient based on their psychosocial behavior. How exactly is a young patient?
As
you
far
can
as
hold on,
COVID,
you can sustain.
Hirenya, as far as COVID is concerned, stick to the guns. Nobody gets it. You tell him, first you use all COVID appropriate behavior and then teach them.
That should be strict. Mask usage, mask and prevention of spread. That should be correct, sir. I agree with that completely.
Yeah, so absolutely, like Udnur sir said, I think moderation is the key. And as far as the vaccine is concerned, I think Pfizer is already talking about subvariant specific vaccines as far as, the specific like influenza.
Surveillance helps for those things for vaccination preparation, or those things, genome sequencing tell about a sudden change in RO number or this thing, that will definitely help us to make a better vaccines in future.
Absolutely. So Bharate sir, since we are talking so much about surveillance and vaccines and about patients in general, so which subset of patients do you think, when you see a patient, which patient do you think is somebody who needs hospitalization?
Very good question, madam. Already Chawla sir has described in detail symptoms. Depending upon the symptoms, symptoms which were described by Chawla sir, malaise, fever with chills and dryness, cough with or without expectoration, body ache, and sometimes patient may present with diarrhea. Along with that, if patient is having respiratory embarrassment or patient is in respiratory failure or patient's cardiorespiratory status is stable and peripheral saturation is below 90, such patient should be hospitalized.
Right. So I think Sir has summed it up beautifully and in really, really brief and very crisp words. So I would like my next question to be Chawla, sir. So Dr. Kulkarni from Bangalore wants to know what is the window time for COVID confirmatory test right from the time of the exposure?
As I told you, first 3 days, this is an incubation time. He reports to you in another 3 days. So first, when he is symptomatic, third to fifth day, if you do the COVID testing, that is the time to get the maximum positivity. That is how you need to address the COVID testing. As Hirennappa has said, there was a time in Delta wave, third day or fifth day, even CT was coming positive. But now in this wave, to see the positivity, you send RT-PCR on third day after the symptoms, you are going to get the maximum positive results.
Right. So my next question, I would want to ask Dr. Niranjan. Dr. Shashidhar from Karnataka wants to know, how do you differentiate whether patient is COVID or swine flu, H1N1 in the emergency?
Based on first from the history point of view, the fatigue will be comparatively more in case of a COVID patient. That is one critical thing. And then the dry cough along with the shortness of breath, these things we can make it out. With the symptoms, we can make it out whether it is COVID or non-COVID. Otherwise, we have to wait for the test, and based upon the symptoms only, madam, mostly we have to go. Fatigue, that is one main key point, I feel.
Right, absolutely. I think fatigue, extreme myalgia are very classical symptoms, and like Chawla sir had said, that a lot of them might have even GI symptoms as now. So, given the current situation.
Can I add something, Shivani?
Yes, ma'am. Sure, please.
So I think currently in vaccinated patients who are coming with reasonably no comorbidities and who are coming with sudden florid symptoms and hypoxia, they are more likely to be H1N1 than COVID. I'm talking about young patients with no comorbid disease and who are vaccinated. So those patients are turning out to be H1N1 because at least in Bombay, that's what we are seeing, that, we're seeing H1N1 currently with more severe symptoms than COVID. In the non-vaccinated, and I'm saying that differentiation. Of course, in the patients who are older or who have high risk or who are unvaccinated, COVID can also present. But currently, we are seeing, patients, yes, more of H1N1 presenting in ARDS.
Yeah, I think it makes sense, ma'am, because I think for the last 2 years, including doctors, a lot of us have actually, including myself, I would say, have ignored the flu shot, which was an annual thing. We were so focused on COVID that we forgot all about flu. So I think it makes sense that maybe that's the upsurge now. G. So coming to Chawla sir again, sir, would you want to enlighten us about the treatment, the management per se in non-hospitalized patients?
See, as Bharate has said, the patients who need hospitalization, they are desaturating less than 93%. Respiratory rate is high. Patient is high-nosed. Patient is hypoxic, gasping for breath, and he has got unsettled fever. So the patients who are asymptomatic or they have mild symptoms, whose saturation is maintained, whose respiratory rate is maintained, there is no need of any treatment. They don't require any treatment except symptomatic treatment with, say, Montelukast or with paracetamol. So if they are absolutely asymptomatic and COVID positive, then you continue the medication for other comorbid conditions, promote the teleconsultation by the patient, promote the COVID appropriate behavior in his surroundings, advise healthy, balanced diet with proper hydration, and ask them to keep connected with their people with all positive talk and positive thinking. So if they develop any deterioration, they report to the hospital. And the self-monitoring with pulse oximeter is very, very important every 3 hours to keep checking the oxygen level using antitussives, antipyretics. If they have an intractable cough, then they can use budesonide inhaler with 800 micrograms twice a day therapy. So, but there is no other COVID specific treatment. These are the Ministry of Health Family Welfare guidelines for mild and asymptomatic COVID, which you have to stick to. And this wave which is going on, all will continue like this. You have to stick to these guns, and most of your patients will become all right.
Correct, sir. I will also like to add maybe something that I tell my patients, that if you have persistent fever beyond 5 days, that's when you should always come back to us. And that's when we will do the serological test, and no other test is needed currently.
Now to add, Shivani, since there is a New England Journal of Medicine, the latest trial which you are going to discuss as an OPD treatment for 3 days of remdesivir for mild symptomatic patients, if the fever is persisting more than 4 or 5 days, because you don't have any treatment except Paxlovid, monoclonal antibodies which are available are having no use on Omicron. You have only left with remdesivir, which is effective. So there is no need to hold on to remdesivir. Convince them on OPD basis, give them 2 shots, stat and 1 every day for 2 days, and bail out the patient rather than hanging on to any treatment and waiting for the catastrophe to come. If the fever is persisting more than 5 days, COVID he is positive, it means he is lingering on. When he will go to the storm, you do not know. So better you use this, and it is equally effective as the 5 days treatment as per the Pine Tree study. Thank you.
Absolutely, absolutely agree, sir.
And can I add a point, madam?
Sure.
Madam, if you are treating patients on OPD basis, we can get the C-reactive protein done on day 1, and serial monitoring of that can be done. And if it is in increasing trend, then we can try to hospitalize the patient. That's what I personally feel, madam, because CRP is an indirect marker of IL-6. Am I putting it in the correct way, madam? Can we use it? What do you feel?
Niranjan, clinically, CRP may be high because of other conditions. CRP cannot be the criteria to have a progression of disease. CRP is a very, very important parameter once the patient is hospitalized. In mild to asymptomatic patients, all these parameters may be IL-6 or CRP or D-dimer or serum ferritin or LDH have no significance and no clinical correlation. Don't get misguided with CRP. CRP is wonderful, but once patient needs hospitalization.
Yeah, I think I would agree. And plus, I don't want to, expose these patients to multiple people to go every day for test, or call somebody over for, doing the test if they're symptomatically all right or they only have mild symptoms. So that's my take on it. I think, of course, with everybody's practice, we personalize a lot of things. So to each his own, and that's why we are having this discussion. So, we can all adapt from each other's practices. So there are questions.
Shivani, I think what happens, unfortunately, with the CRP in the general practice, not with pulmonologists, but when you have general practitioners, is when they see a high CRP, they start steroids on OPD basis. Okay, so that can also have adverse implications. So I think CRP, as as you all have discussed, is that it is primarily to look at disease progression in admitted patients, not really in patients who are mildly symptomatic and all, because they have a risk of, somebody seeing, oh, that CRP is high, my doctor gave me steroids, and you meet my doctor, and then, then you have all those issues related to steroid overuse also.
Absolutely. And we don't want to give early steroids anyways.
Yes.
Absolutely. Perfect point. Right. So since we're talking, and okay, so there are questions from Dr. Koirala, and I think in the course of the discussion, we are answering your questions, Dr. Koirala. We've discussed the mild and moderate, and we will obviously go on to discuss it further. So, but right, because when we are talking about mild and moderate cases who do not need hospitalization, Udnur sir, can you please talk about Paxlovid? That's like something that all of us are practically not exposed to yet.
The Paxlovid. So as we know, there was a search for a good antiviral. So H1N1 is a disease. We have oseltamivir, which is a very good drug. It is disease specific. We don't have anything. So if by this time you would have got an excellent drug, which is antiviral, which is going to work for COVID, we should not have had a discussion. So remdesivir is a drug which is not made for COVID as such. We started using it. We found the response. And people, there was a huge cry, remdesivir will not work. People, we still use remdesivir. Now the discussion has come to 3 to 5 days. So we are search of, this is IV administration drug. There was a search for making a oral remdesivir also initially. So initially we used ritonavir and the combination antiviral, because it is a viral. You used to use antiviral which are used for HIV, and those drugs were used. And there was a search for this antiviral which will affect, which will have a good effect on the COVID. So then we started using favipiravir, which is a broad spectrum. It will cover for H1N1 also probably. And it was used, and there was 14 days course. Then it came to 7 days, 10 days. It went on, and there was a search for a better antiviral, which has a slightly molnupiravir was come into a picture, and which has less number of duration for viral phase, and the number of pills were high, and it was being taken off. It can be used only in though across the reproductive age group, maybe 60 and above. That was there, and there was something search continued for a good oral drug which can be used within 2 or 3 days or 5 days of symptoms, so that they can be managed at home. And one drug as such is being developed is Paxlovid, which is an antiviral, which is a combination of more of ritonavir and nirtalamivir. So I don't know, it's not available. So sometimes the combinations, 3 drugs morning and 3 drugs night for 5 days, they have seen compared to a favipiravir, molnupiravir was better, 30% reduction. They have found that Paxlovid has a better reduction in the risk of hospitalizations and better antiviral. That has shown a lot of promise, and compared to other things. Only time will say when these drugs will come into a market, and when we start using it with the different kind of things, we will find the place of Paxlovid at a certain age group probably, or a certain time duration. And if it really surges fast, and it can be given as mass administration. As of now, it is not available in India, but that is showing some promise as a good antiviral when we have a IV and a oral counterpart for molnupiravir at this point of time.
You know the beauty of Paxlovid? It is manufactured in Bangalore. It is manufactured in Chennai for export, not for Indian population.
Why? What is the reason for it? I don't know. I am not aware of.
So you must let us now.
Please throw some light on
this is not the platform for this, but this is the truth. If you pick up a pack of Paxlovid available in India, it is made in Bangalore. It is made in Chennai for export. You want, I can send you the WhatsApp of that made in to you, and it's available in the country. Provide the DCCI
approval.
Reasons are well known to them, and let us not get into this.
Maybe it has to come from the West.
Right. So my next question is to Pratibha ma'am. Dr. Dalal wants to know the role of remdesivir in patients with comorbidities, vaccinated or unvaccinated. Ma'am, I think you're on mute.
So good. We are discussing remdesivir. Everybody thought that it is completely now, once all these oral drugs came in, everybody said there is no role of remdesivir. There were even some hospitals who stopped stocking it in their pharmacy. But there's still a role of remdesivir for sure. There is data that we are talking about. So going back to the genesis, something that Dr. Udnur also mentioned, that remdesivir was originally used for the Ebola virus. And because at that time we did not have any other thing, we decided that we will use it. There were some studies done immediately, like the ACTT study, which basically was looking at placebo versus remdesivir in patients who were hypoxic, and they saw that there was a improvement in discharge time in patients compared to the placebo, and in patients who had significant hypoxia requiring oxygen, the time to recovery was lesser, 11 days compared to 18 days in patients who were not using remdesivir. However, since then, there were trials like the Solidarity trial, which has studied all these drugs. And basically, as we all know now, that remdesivir will do nothing for a patient who is already on ventilator. But yes, in patients who are mild to moderate, definitely, if given at the right time, it will improve, decrease the time to recovery, decrease the hospitalization time. And since then, the initial studies said that you need to give it for 200 milligram on the first day, followed by 100 milligram for 4 days. And then there came a trial in NEGM, which basically spoke about remdesivir on an outpatient basis in patients who had less severe disease, but so basically not requiring oxygen. Symptomatic patients with at least one risk factor for disease progression, like they were 60 years or older, they had comorbid disease like hypertension, diabetes, CKD, lung disease, malignancy, or any of those spectrum of risk factors that we know that can have a high risk to progression. When you're given this remdesivir for 3-day course, 200 milligram on the first day, followed by 100 milligram for 2 days, that also showed that there was an significant risk reduction in progression to severe disease. And therefore, now it is recommended that even in mild patients, but who have risk factors, you will use remdesivir as a 3-day course. And these are patients who are not hypoxic. So we are starting remdesivir early in patients who have risk factors and who are patients who are not hypoxic. The moment the patient is hypoxic, we are going to continue the 5-day course. So that is the main difference. Of course, as Dr. Chawla said, on OPD basis, I don't know, but the hospitals that I am attached to, we don't have an isolation daycare facility for COVID positive patients to come in to take remdesivir. I don't know how it works in other places. So often, the issue in India is that very often patients who are symptomatic and who have comorbidities and who remain symptomatic with fever beyond 3 days, they tend to come into the hospital anyways for admission because they don't have always a facility to come for doing an outpatient basis injection. So I think that should summarize, because we have different, in our setup, we have some limitations where, then you admit a patient, give remdesivir, see that the fever has gone away, symptoms are getting better, patients are not hypoxic, and discharge the patient in 3 days. I think that is also sometimes that what we need to practice.
Pratibha, remdesivir has stood the test of time from
Yes.
wave 1, 2, 3. So what was it, but what it is today? And if you convince the patient, there is no need of admission.
Correct.
Take for 2 doses and take 2 start and 1 every day. People are happily taking. And let me tell you, I will not name any of the celebrity doctors or anyone suffering with COVID, fever persisting more than 3 to 4 days. The local language is used, 3 din remdesivir lo or chutti. Thank you very much. Fever subsides and it is working. It is the only drug which is working. Since Paxlovid is not available as a 15,000 rupees course for 5 days. I will not say it's not available, but it is available without the permission of Government of India. I have sent the copy on this. It is made in Telangana, sorry, Bangalore. So I have sent you. It is available, and it is available for the public also, provided you know where to take it. Government of India is not regulating. It is reasons well known to them, and it is very effective. So give a choice to the patient. Pick up this or pick up this. And I am sure there is no need to play with COVID.
Yes. So till the time it's officially available at this point in time, I think, we have to choose remdesivir over the other. But yes, of course, we know that the moment we have, anybody would like to take an oral drug more than an IV drug, Dr. Chawla. So, I mean, even ourselves. So I guess that's where the...
Yeah, except I think, ma'am, because there are a lot of drug interactions and these patients mostly will have comorbid conditions. So I think that's probably the only catch, wherein, of course, not just the availability, but also from that point of view, I think we will prefer remdesivir. I agree. So my next question is to Bharate, sir. So can you, we've obviously talked so much about remdesivir, but what is your line of management in people who do end up getting hospitalized for COVID-19? So what is your line of management other than remdesivir?
When patient is admitted, first of all, we should check his basic parameters and whether patient is requiring, if patient is requiring if his oxygen saturation is below 93, then oxygenation should be given. Then along with that, IV access line, then IV fluid should be maintained for proper hydrations, and to check if patient is having secondary infection, proper antibiotics should be given, and these antiviral drugs, I will prefer to remdesivir. So stat dose like injection remdesivir 200 milligram stat and 100 milligram for at least for 5 days, or it can be extended up to 7 days also, depending upon the situation of the patient. Then along with that, we have seen if patient is having comorbidities, then again there is question whether to use methylprednisolone or dexamethasone. But few studies has few studies has data shows that instead of this dexamethasone, while using the remdesivir, methylprednisolone is beneficial than using dexamethasone. So proper hydration, antibiotics, antiviral drugs, along with multivitamins, vitamin D supplementations, and protein, high protein diet is very important in hospitalized cases.
Right.
And prophylactic anticoagulants.
Yeah, yes, sir. If these serological tests like serum ferritin level, D dimer, and LDH level, we should check time to time. If D dimer is positive with higher range, then we can start these low molecular weight heparin.
Right. So I think more or less the management of COVID in hospitalized patients remain the same as it has been in the preceding waves. Right, sir? So my next question is to Dr. Niranjan, because I think in between all of these things, the last wave we heard a lot about antibody cocktails. Of course, Chawla sir had some time back mentioned that it has no role. But what is your take on it?
Personally, I feel that antibody cocktail is not more effective than remdesivir, madam. And as such, it contains of two components, and it is preferred only for mild to moderate cases, and it should be given at the initial time when there is no oxygen requirement. When oxygen requirement has already started, people suggest not to go with antibody cocktail, and the price of antibody cocktail also remains an issue while using. It is better to use in the first 3 days of illness, madam. The COVID key rule is the correct drug at the correct time. So comparatively, we should get it done within the first 3 days if we are planning to use it.
Right, absolutely. I think, yes, cost remains a very, very major issue because the cost is over 1 lakh. And if you do not have 2 people, half of the drug actually goes waste, and then one patient ends up bearing the cost of the entire thing. So certainly cost. And then I don't think studies have shown such promising results in terms of antibody cocktail. However, when it had just come into the market, I had a lot of my friends from down south who would say that patients would just walk in, especially elderly people with comorbidities who had just got diagnosed with COVID, would just walk in and say, ki hame, we want the antibody cocktail. And then they would obviously give it. So I don't know, my colleagues from...
if the patient is more educated and more wanting to take it, then we give it. That's why they ask for it. And then you make a pitch of it. Most of the time, it was like that in the situation.
No, you should not give this message. It is not effective against Omicron. The message...
No, sir. It is not effective against Omicron.
No. You should not give this message at all. That patient wants it, so I give it. Nobody will
I didn't say that, sir. I didn't say that. I
No,
didn't say
whatever
most
it
of the
is,
time.
whatever it is.
Most of the
And
time when they come,
no,
when we
as
say
far as
so
Delta was
antibody
concerned, Delta was concerned, very effective
was
for
yes,
Omicron, it
yes,
is
sir.
useless.
Yes.
So there is no need that antibody cocktail, if patient is asking, make him understand, better take remdesivir even in mild form rather than asking for the antibody cocktail. Question
Sir,
is not of money. No,
yes,
it
yes,
should
yes.
not be discussed. It should not be given. Thank you. It is a
No.
message to the audience.
Yes, sir, I agree with that. What exactly was happening in the situation I was telling in the last COVID wave, what exactly was happened? Because antibody cocktail, when the Trump took it, there was a huge cry about it, and everyone was asking for antibody cocktail.
That was
So,
Delta.
and the antibody cocktail was not useful in Omicron. You have mentioned it, sir. It's absolutely clear. So now also antibody cocktail is there. The cost effective cost, it is very costly treatment. So patients with comorbidities and risk for worsening, there was huge pressure from all sides where this has to be given. So most of the time we never used to suggest it. So to give that point of time when there is a high infective load and lots of patients were standing, it needs lot of face-to-face discussion. So that was becoming very tough. Most of the time we used to defer it. See, it's okay, the saturation is okay, it has elapsed the state. Sometimes we used to make lots of discussion. We used to lose the battle because most of the time, okay, it's 3 days, okay, if you want to take it, it was like that message which was happening. Now the clarity has come with the people like you, when they are very clear in the thought process, and the guidelines are being saying that now the present wave is Omicron, it is not used, means we will not use it. I'm not telling I'm not telling it, I'm not promoting antibody cocktail at all. This was the scenario. Now also we are not giving more of antibody cocktail, giving it OPD basis. It is extremely tough task, and having a isolation area for a COVID specific area to give that is also is a tougher challenge. Sometimes we have side effects and all those things. Consenting is too much of a problem with the antibody cocktail. I agree, and your thought process is completely message taken, sir. It is truth, and I am glad that you answered this question and more effectively by telling it. The message is that we should not give it to everyone. Now Omicron, definitely no. The risk factors of worsening and more than 60 with lots of comorbidities, it has a role initially. Probably that is await. Some drugs have come in vengeance to act, and this with lot of promise. Over a period of time, with the trial and error, we are noticing that it is when a low dose saturation is there, low supplemental oxygen, remdesivir, steroids, Dexona is 6 milligram equivalent with Clexane, 3 pillars of the treatment is enough. With CRP and monitoring is a better strategy, I feel. You nailed it, sir. Thank you.
Yeah, absolutely correct, sir. I think like you have both been saying that in the current situation, there is absolutely no role of the antibody cocktail.
True.
And having said that, of course, there are multiple issues, and no study has shown its effectiveness, especially like sir said in the Omicron.
True, I agree.
It is totally out as far as COVID management today is concerned. Absolutely.
Yes.
Right. So I would like to, Dr. Kulkarni wants to know, Chawla sir, I'll request you to please answer this question. Why in some people there will be no reaction following even the booster vaccine?
Now, you must understand the antibodies which are measured are not the what you call as the neutralizing antibodies. The kit with which you are measuring the antibodies are very important. So there is no need to get disheartened that after the first vaccine, after the second vaccine, after the booster, if the antibodies are not visible to you, you are protected. You are protected beyond doubt against severe illness, against moderate illness. So seeing antibodies level is no criteria that vaccine is not effective. Vaccine is effective at the memory cells level, at the T cell level, which you are not measuring with the routine antibody kits. So there is no need even to measure antibodies, rather than they are just commercializing. There is no value, there is no role of measuring antibodies post-vaccination.
Absolutely. So what we are measuring, actually the value that we get is the spike protein, whereas I think what we should be measuring, like sir said, should be the nucleocapsid content, which none of the tests are actually measuring. Hence, these tests are only strictly commercial value and have no value at all in the clinical practice. Am I right, sir?
Correct.
Yeah. So next question I like to address to Bharate sir. Sir, Dr. Raman Kumar from AP wants to know if pneumococcal or influvac will help to prevent COVID.
Pneumococcal or influenza vaccine will prevent the influenza or influenza diseases, not the COVID.
Yeah, absolutely. So influvac, like we've discussed, is all about swine flu and should take the annual shot, and pneumococcal, as it is recommended in very specific recommendations for pneumococcal vaccine again, and has only action against pneumococcal strains, very selective strains. So absolutely no role in the prevention of COVID infections. So again, next question is there any place for tofacitinib or baricitinib this time for steroid sparing situations? At that point, we saw a lot of these drugs being used, including, in severe cases, even tocilizumab, etc. So where do we stand with this today? Udnur sir, would you like to answer this, please?
It is regarding tocilizumab, baricitinib, and these are earlier, whatever the trials with dexamethasone 6 mg equivalent was used. So we are using more steroids. Sometimes in a first wave, we use pulse dose steroid. Then we cut down to more of methylprednisolone. We are more methylprednisolone friendly, and neurologists are more dexamethasone friendly. So we used to give 40 mg 3 times daily. In flu, we used to give 125 mg infusions. It was like that. So over a period of time, when this black fungus came in, and we started using based on the trial of dexamethasone 6 mg equivalent, which comes to around 100 to 150 mg of hydrocortisone. With any steroid is a steroid. Methylprednisolone is 40 mg once daily. But when you didn't know the things of IL-6 and which is a cytokine storm marker, we need more steroid. Either the IL-6 used to come in spite of using low dose steroid 6 mg dexamethasone, and after 3 days of giving remdesivir, dexamethasone, and we have markers with CRP and IL-6. Yeah, IL-6 level is normally less than 6 to 10 probably. In spite of steroid, remdesivir, and other things, within 3 days or 72 hours of admission, if IL-6 levels are persistently high, more than 60 to 75, then we can't give more dose of steroid because we are immune suppressing in, and we have an alternative like 1 shot or 2 shot within 72 hours apart. Tocilizumab, it was availability was a problem. Then they were looking at a new drug. It is 400 mg, 1 stat dose used to use it as a steroid sparing drug. And since it was costly and availability was a problem, they were searching for a new drug. And then came the role of baricitinib and tofacitinib. Tofacitinib is used for more of rheumatological, rheumatoid arthritis, more of 10 mg twice daily. And we used to give it as a instead of tocilizumab, but this has to be a oral form given for 10 days to 10 to 14 days, and based on the IL-6 monitoring. And baricitinib on day 1, when they are used with remdesivir, low dose supplemental oxygen, and dexamethasone 6 mg, after 3 days, if IL-6 is persistent, we add instead of tocilizumab, baricitinib, if it is added with remdesivir. First day it is 4 mg twice daily, and then next 13 days it is 4 mg once daily. And it has definitely helped to get down the second week illness. What sir said, in the second week there is a chances of cytokine storm. It is unpredictable. Sometimes patient is doing well in 8th or 9th, suddenly oxygen requirement goes up. That's the time we want day 1 only you can add baricitinib. That's why we are using that. And this is used basically to prevent any super infections, because on treatment with a viral disease, you treat it so aggressively that you immune suppress him and make him prone for secondary infection, gram-negative sepsis, and sometimes having mucormycosis is actually a curse. And treating mucormycosis, we should not get into those situations. You can take it treat for 50 days, 60 days in ICU patient, ventilated, came out, rehabilitated, 70 days they are gone, they have not got any mucormycosis. When you are used low dose steroid for a longer duration, rather than using a higher dose of steroid, it is not good. We can use a steroid sparing agents, see the markers, get it, treat it enough so that they have minimal oxygen, not go on a ventilator. You can manage it doing with pulmonary rehab and other things for a longer duration, watching for super infection. That's how I see the use of tocilizumab, baricitinib and tofacitinib.
Right. So I also felt that in patients who were ventilated and we used tocilizumab, I think there were certainly way higher incidences of secondary infections and patients landing into sepsis. That was my personal experience.
Yeah. So if the counts and infections rates are high, we try to balance it out. Means whether it's the inflammation which is more or whether it is a sepsis component. Sometimes we see do a procalcitonin NC and antibiotic cover we give, especially in diabetic and all. We make the people can come out of COVID well, and they will have something more, and that can actually kill them.
See now, baricitinib, tofacitinib, or your tocilizumab, the drugs, once the patient has gone into severe moderate and early moderate, these drugs were effective before early moderate. Once the patient is in severe moderate and severe illness, goes on ventilator, any amount of these drugs were all useless.
Yeah.
Patient went on ventilator, hardly 1% of ICU admission you could save, rest has gone to mortality. Tocilizumab, abdominal perforations, massive rectal bleeding, massive infections, rather than helping you, it has harmed your patients.
Yeah.
So if you think drugs were helpful to you in a severe illness or the severe moderate illness, it's a true blatant lie. All drugs were useless except your remdesivir, steroids, no molecular weight
anticoagulant.
You could save them. Otherwise, if they survived with their luck, not with your repurposed medicines. Today, with Omicron, all these drugs are useless. There is no need of using these drugs at all. Mild symptoms, mild medicines, and let them get all right.
Right.
True. Well said. Well said. I agree that point with so authenticity, and I think the message is clear. There are lots of drugs which are there in market. Sometimes if they are there in the market, we'll tend to use it. But remdesivir and anticoagulant and low dose steroids with dexamethasone 6 mg, they do wonders irrespective of other drugs. We rarely need them. We add it based on the situation, and too many high-end costly drugs may not be required.
Right, absolutely. And I think apart from just the drugs, the one thing that really helped the patients was ventilator strategies, and especially proning, I think, saved a lot of patients. It practically saved the day in cases of severe ARDS, wherein on a high 100% FiO2 high peak, patients were not maintaining saturation. I think proning these patients really helped them get them out of the ventilator.
I want to add it. Those patients, young patients who came sick directly and to the ER, it's requiring high ventilated, they ventilated day one only, they will come out faster within 5 days. That's what I have seen. Some patients who are being admitted, they become worse 6 or 7 days. You start high flow oxygen, go on a ventilator, they post intubation, they will crash. Sometimes it is better to become so bad ill at ER only. The decision of ventilator is unambiguous there, and we intubate, do a prone, ventilate, give remdesivir and all. Patients have been extubated on 5th day, and that has happened. That is my observation, which I have seen. Sometimes patients, elderly who have been worsening, they went on downhill irrespective of whatever you do, all the things correctly.
I think, sir, also those patients were lucky since they got an ICU bed at that point. So my next question would be to Bharate, sir. Sir, what do you think is the ideal duration of anticoagulation? We've been talking about LMWH or giving some kind of anticoagulation. And in those days, we were actually even giving patients oral anticoagulation on discharge. So what do you think is the ideal duration to give them anticoagulation to monitor their D dimers or serum ferritin or LDH? So what is your take on that?
As a when patient is admitted into his D-dimer level, his or her D-dimer levels are high. In such patients, low molecular weight heparin should be continued for 5 days, and in between we should check his or her clotting time, bleeding time, and prothrombin time also, so that there should not be there are chances to avoid the risk of internal bleeding also. So minimum 5 days should be minimum 5 days. These low molecular weight heparin should be given, and on discharge. Uh, Again, I think there is no role of giving these oral anticoagulants in post-COVID cases. It has been seen.
See, Dr. Ramesh, there is a study in New England Journal of Medicine with 2 options. Hospitalized patients, you give oral, so give IV anticoagulation therapy and send without any prophylaxis, or you send them with prophylaxis. You have 2 different options. But if you go by the risk of thromboembolism at 30 days is low, it is 0.6% if you have not used the prophylaxis. And the major bleeding chances are 0.7%. So you have to evaluate both the things before writing any prophylaxis. Rightly you said there is no role of the prophylaxis, and if at all you are giving, the duration is 14 days to 35 days with strict monitoring, seeing all the factors that patient should not have any condition where there are chances of bleeding or more. So you have 2 different options, but conclusion goes is there is no role of prophylaxis when you are discharging the patient. And if the hospital stay is more than 5 days, it is good. If the hospital short stay, then you can choose to use it as prophylaxis to cover that hospital portion at that time.
I would like to add, we have seen the patients in a second wave or third wave, where the patient has come disproportionately hypoxic with the CT. We are thinking only of HRCT and ARDS. If we have sent the markers, sometimes the D dimers are disproportionately high, 35,000, 10,000 and all. That time we have avoided doing, if they already come with this with hypoxia, we have noticed that there is a ground glass patching along with a massive pulmonary embolism. And that time there was a requirement of thrombolizing also. When there was a hypotension, there was a 2 component of hypoxia. So they have come with a thrombus sitting, and they have a parenchymal issue also. So we should use the D dimer effectively. Sometimes they come with a DVT also with presentations, which is progressive, means you need anticoagulant. Those situations, any hospitalized good DVT prophylaxis in the hospital patients in a medical illness more than 2 days or 3 days, that is a good practice. In that, if that practice is going on, that actually helps in following the guideline also. So we are using D dimer as a tool, as a marker for using an anticoagulant. If it is significantly higher, we used to use twice daily, and seeing the echo, RA-RV dilatation, RV dysfunction, whether you require a CT angio or a plain HRCT. Sometimes we screen for DVT also. If you don't have a CT angio negative, you have found out the DVT. So we have to look for thrombolizing indication is not there. It's not a massive thromboembolism. Just prophylactic anticoagulant is in a hospitalized patient is definitely needed, because COVID is a prothrombotic state. Even otherwise on 10 days, 15 days, they might have developed pulmonary embolism. And I definitely agree with the point. There was huge debate whether we have to give 90 days post-COVID the anticoagulant, whether we have to give 30 days. Nobody knew. Sometimes we started using, initially we used to give more of anticoagulants for 10 days, 15 days, make sure they come for a follow-up, and we change it to echosprin. And these kind of things. So definitely if there is a heart problem, they need echosprin. They are more prone. And so we are using less nowadays. Whatever we used to use apixaban, that we have started using more, and we learned about all these NOACs in this COVID, and some sense has prevailed which patients we have to choose a anti-thrombotic drug at discharge. Hospitalized, yes, we are doing it a great job using low molecular weight heparin, and very good job in this thing. At the discharge, what exactly is the guideline says, we really don't know which patients we need to select based on their comorbidities, cardiac and other things. And provided the D dimer is not significantly high, we try to avoid it. And I feel that is the strategy which I am using. I feel Dr. Chawla should be able to add more to it. That's what I do.
See, when you have pulmonary thromboembolism, you are treating as per the guidelines of treatment of thromboembolism.
Yes.
You have
yes.
You are treating a DVT.
There's no doubt.
But we know there is a microthrombosis in cases of COVID. It's very clear now. If you go through the studies of the New England Journal of Medicine, they are very clear. You have two ways using these NOACs, whether if the patient gets bleeding rather than a benefit. I told you the benefit is 0.6% in 30 days, where there is a bleeding chance is 0.7%. So you have to weigh if the patient doesn't have any comorbid condition, patient is absolutely stable. So you need not, if the patient is cardiac, he's already on ecosporin at Orvas. You in any way will not stop it, either during the treatment of COVID or after the COVID. Thromboembolism, you are going to use prophylaxis for say 6 months or even up to 1 year. You don't have to follow it up even with your INR also. So you
the vague and ambiguity is in non-thrombotic, only D dimer 1000, 2000, 3000 without anything.
You follow any parameter. But if the patient is COVID, no comorbid conditions, if you used to choose, it is 14 to 35 days. But the main recommendation is there is no use of prophylaxis at home at the time of discharge. It is very clear. There is no discussion.
Thank you, sir.
Right, absolutely. So that gives us a lot of clarity and answers the question on anticoagulation. So, ma'am, since we're talking about these adjunct therapies, we've discussed the three main stages of therapy when it comes to COVID management. But all through the first and the second wave, and even now when we get patients, they're very hyper about, taking vitamin C, vitamin D, zinc supplements. So what is your take on that today?
Good question. So there is, since the first wave, there has been now recently many meta-analysis which have studied all the studies on these three supplements. And there was a meta-analysis on the vitamin C from the AIMS clinical epidemiology group, which was published recently, and which basically they looked at 6 RCTs where 572 patients were studied who received vitamin C treatment, and they saw that vitamin C did not reduce mortality, did not reduce length of hospital stay, and also did not reduce the risk of need for invasive mechanical ventilation. So conclusively, what they have conferred from all this meta-analysis of all the studies on vitamin C is that vitamin C, there is no significant benefit in COVID-19. So definitely vitamin C is probably something that we should not be recommending to patients. As far as zinc is concerned, there has been meta-analysis done on all the studies prior, which was published in European Journal of Medical Research. And basically what they found is they looked at 5 studies with 1,506 participants, and they looked at the zinc supplementation led to a significant lower risk of mortality when it was compared with the control group who did not receive it. So at this point, they have suggested that zinc is associated with the lower mortality in COVID-19 patients, and it could be considered as it is a simple cost benefit effective way for reduction, and they did not see any harm related to zinc supplementation. Now, vitamin D actually has been the most interesting amongst all of this, because there were many studies which looked at vitamin D, and there was again a meta-analysis of 7 systematic reviews which showed that vitamin D supplementation reduces the risk of mortality with a significant p-value in COVID-19 patients. It also decreased the need for intensive care with an odds ratio of 0.35, and decrease the risk of mechanical ventilation in the patients that were studied. And basically, they also reported this meta-analysis that the studies were robust and reliable, as the level of heterogeneity was reasonably low in all these studies. And therefore, vitamin D supplementation was found to be effective in reducing COVID-19 mortality. Now, the interesting thing about vitamin D, why we are talking about vitamin D, is basically we know that the viral infection is defense is provided by the T regulatory lymphocytes, what we call as TREGs. And TREG levels have been reported to be low in many COVID-19 patients, and these can be increased by vitamin D implementation. So again, low vitamin D levels have been associated with an increase in the inflammatory cytokines and an increased risk of pneumonia and viral respiratory infections. Now, also it is associated with increased risk of thrombotic episodes. So all in all, vitamin D seems to be a very interesting role and could have good role in implementation. Now, going ahead, vitamin D is found to be low in patients who have diabetes, obesities, and in other states where there is, infection possibility. Also, vitamin D is supposed to be lower in people, ethnic races, like Hispanics and people of the African origin, and which was found that in America especially, that these people had a worse prognosis and outcome in COVID. So there could be some truths to this fact that, maybe vitamin D supplementation again is something that at this point in time, as per the meta-analysis, is shown to have some benefit, and therefore it can be recommended. So at this point, looking at all the data, I would say vitamin C you would not give, but zinc and vitamin D, has a role in as supplementation. And anyways, I think currently when you're looking at patients, mild patients, they all want something, right? And if there is proof that these two things do seem to work, why not? Rather than giving them all these other cocktail of antivirals and all, which is not needed, you may as well give them something where there is benefit.
Yeah, absolutely agree, ma'am. And I also think the various studies which show that vitamin D per se is deficient even in Indian population. Almost 80 to 90% of the population suffers from vitamin D deficiency. So might as well correct that.
So basically in the darker skinned population, it is supposed to, there is an inherent deficiency of vitamin D.
Right. Absolutely. So my next question is to Dr. Niranjan. Dr. Niranjan, what do you think is the role of antifibrotics in COVID today? When it began, I think Nintedanib actually came at a much lower cost along with COVID because it was being so rampantly used. So what do you think your take is on antifibrotics today?
Now, dating back to PG days, that time we used antifibrotic only for ILD cases. Then after that, when COVID came, we started using this. I still remember during the first COVID wave, we got Nintedanib for 20,000. Then the price slowly dropped down to 5,000. I personally feel more than Pirfenidone, Nintedanib does better. Pirfenidone won't stop will stop only the ongoing fibrosis, and the previously fibrosed it won't have any effect. Nintedanib comparatively is a safer drug, and Nintedanib patient compliance is also comparatively good because GI problems are already more in the COVID patients. Giving Perfenex can add to the GI problems. So comparatively, Nintedanib is a better drug. Madam, when we started to give post-COVID for fibrosis, certain physicians used to ask, you are giving antifibrotics for post-COVID fibrosis, then why is the rationale that it is not used for post-TB fibrosis? Many people used to ask. I would like Chawla sir to little brief on that.
Correct. It's a controversy. You are correct, and their question was correct to you. Why not for a fibrosis of tuberculosis? Why fibrosis of COVID? This drug was as tried. Company wanted to promote it, seeing there is a fibrosis going on in COVID patients. They came at that time when patients were getting long COVID and a COVID fibrosis, but the drugs have absolutely no use. They were totally useless, and nobody should recommend it for post-COVID fibrosis. Those, if you have sequence of these CTs, HRCTs for 6 months, you will see they self are resolving. The CTs are becoming absolutely normal. This was never a progressive lung fibrosis. It was a fibrosis, definitely, but it was resolving with a period of time. And the amount of fibrosis which remained residual and patient remained dependent on oxygen went for lung transplant. There is never a role of pirfenidone or nintedanib in post-COVID fibrosis. Either the patient has proceeded to lung transplant, or he is dependent on oxygen, or it has resolved at its own. It's clear. There is no, because experience of every one of us have used these antifibrotics, and everybody knows the truth is, like Pratibha said, vitamin D is up, zinc, kuch to de do, patient aa gaya, vitamin C, kuch to de do. We are not harming the patient. To make him happy, everybody started using antifibrotics, but the truth is they are not useful at all for COVID fibrosis.
Agreed with the statement of Chawla sir, because I have seen thousands of patients.
So, if I may add, I think in the first wave, most of us have been guilty of giving it to patients who are oxygen dependent. Sorry, go ahead.
Yeah. I completely agree, but low dose steroid sometimes helps. Low dose like 5 mg of this thing for a longer duration. So instead of using an antifibrotic, a low dose steroid, if they are hypoxic, requiring, means they have come to 10 liters to 9 liters. It took longer time to get their oxygen with breathing incentive spirometry. Sometimes we keep at a low dose, 8 mg, 4 mg of methylprednisolone. That will definitely help with the ongoing to prevent the fibrosis, because GGOs responds well with the steroid.
Dr. Udnur,
I think, can I say something?
When we make guidelines, there is UPP, right? Usual practice points. So you may be having, but you cannot give this message to
Yes, true. I agree, sir. I agree, because see, it's like guidelines are this thing in a practical situations. Patients are not improving. Sometimes we definitely
your experience, but telling to the masses ahead, it is different, totally different.
Yes.
Ma'am, you wanted to add something.
Yeah. So, there was a very interesting article by Professor Athol Wells, and we know that he is a big authority on interstitial lung disease. And I think initially all the data that was coming out was basically from long-term studies, 15-year, 10-year studies of MERS and SARS survivors. And they found that even in those patients who had frank ARDAs requiring high oxygen, the actual percentage of people who developed fibrosis was much lower. It's just that in COVID, because of the sheer numbers that we had, all of us have been guilty in the first wave of, some patients were started on antifibrotics, but we saw that patients who were not started on antifibrotics also at the end of 1 year, 1.5 years, even when they had very bad disease and very bad CT scan findings at the time of discharge, still showed resolution. So Professor Athol Wells actually summed it up very nicely, saying that this is actually not fibrosis. We're using the term very loosely. It is actually post-infectious residual changes, which we need to give time to resolve. If there's progression of the disease, then only you can call it fibrosis, and then you are talking about maybe there is some merit of giving antifibrotics. Otherwise, definitely now we know, as Dr. Chawla said, by all experience now we know that there is no role of giving antifibrotics in these patients.
Right, perfectly summed up, ma'am. And I think in the first wave, like you said, it was more like a do and die situation.
Absolutely.
Do and die, because all of us were practically directionless. We didn't know, there were no guidelines, there were no directions. This was a new disease to us. So we were all trying whatever we could and whatever we thought would help the patient recover. But eventually, I think in our experience, we also saw a lot of role of pulmonary rehab in these patients who were oxygen dependent, even beyond 2 to 3 weeks. And pulmonary rehab, maybe for aggressively, if done for 3 to 4 weeks, most of these patients were actually off oxygen. This was my limited experience. So I think pulmonary rehab had a much better role as compared to antifibrotics in these patients. So we have few more questions. Should we expose these patients to unknown toxicities of molnupiravir? Chawla sir, would you like to add to this?
See, molnupiravir is a drug which has been written off like favipiravir. Because when Paxlovid is there with 80% effectivity, with remdesivir at 80% effectivity, molnupiravir, and then in the reproductive age, you cannot use it. It has got its own reasons. Those who are in non-reproductive age, you can use it. The same amount of medicines you have to take, 8 tablets per day. There is a pack of 40 tablets with effectivity of hardly 30%. If you ask me and go by the studies of ivermectin, I will choose better ivermectin and doxycycline, which the people used. Now they have written it off. They may be the market politics, pharmaceutical politics, gimmicks. If you go by the studies of ivermectin, it clearly edges over any of your antiviral drugs. For mild to early moderate disease, ivermectin still scores. And there are, if you want me, I will definitely quote you the studies. It is a systemic review, meta-analysis, and trial sequential analysis to inform the clinical guidelines. It reduces COVID-19 infections when ivermectin was used as prophylaxis. The more favorable effect estimates for mild to moderate disease compared with severe disease for death due to any cause. On the evidence of demonstrating reduction in deterioration, the dose was 0.2 to 0.4 milligram. And if you see in Bangladesh and Argentina, they involved 1,195 health workers and have shown apparent reduction in COVID-19 transmission, ivermectin prophylaxis. Even in India, trial of health workers of 3,532 participants, they clearly showed the value of ivermectin. In second wave, if anybody says he has not used doxycycline and ivermectin in his prescription, he probably will be lying. People knew this is the medicine which my doctor is. They got printed on their prescriptions. If you compare molnupiravir and experience of ivermectin, it any day scores over molnupiravir. Molnupiravir is gone now. Favipiravir is gone now. You are talking of either Paxlovid or you are talking about remdesivir. And if any variant comes and the monoclonal antibodies are effective, they will again come back with different antibodies. As you said, you are talking about bebtelovimab. They may be effective for Omicron. But the available monoclonal antibodies not available, not useful. Paxlovid, I told you, in the market available, remdesivir available, and ivermectin is available. Still, the drug for Omicron, these all drugs are not required actually at all. So we do not know their effectivity in Omicron. You need only paracetamol to treat this strain. But as far as Delta wave was concerned, any day, ivermectin has scored over all these antiviral drugs. Now we don't need it. So we do not know actually how effective ivermectin will be. But Indian drug with low cost, the pharmaceutical companies of international will never allow it to score over them since they have to sell it to the system.
Absolutely agree, sir. I think in the first wave, we all started with HCQS and then subsequently ivermectin prophylaxis ourselves as doctors. So I think we've all had ivermectin. And I really think that, whatever OPD patients, when we were using it initially, we found it extremely effective. And so the team informs me that there have been around 870 logins for today's program session so far. We still have few more questions to answer, so we'll maybe extend it for some more time. Dr. Bharate, will you want to answer this? Do we still state the third dose as booster when it's the precautionary dose, as we know about the T-cell memory now?
I think Chawla sir will answer better than me.
Okay, see, now when we are talking about the first booster or a first precautionary dose, people are talking at the same time the second booster and a second precautionary dose. Only the Israel had this fourth dose, and they have shown after 6 months of the third dose, which you say precautionary dose or you say booster dose, even the fourth dose is effective, but there is no mass recommendation for the fourth dose. But the third dose is definitely enhances the protection against severe disease for people 18 years and above, and it should be taken, and the message should go. You can motivate any number of people, because after the second dose, you have breakthrough infections. If the patient gets a breakthrough infection, let him not take this booster. Let him wait for 4 to 6 months and then take booster. And people have measured the antibodies and they have seen the effect. at least for 6 to 7 months, the immunity is persisting. Even in few patients, they have seen for 8 to 9 months. So the booster is effective. It is definitely saving you from the severe illness, from the moderate illness. What you are seeing as a mild illness, it is all because of your vaccination program, which India has scored all over the world. So third dose as a first booster is very effective. I'm sure the recommendation soon will come for the fourth dose, which will be the second booster, which Israel has already using for its population. America, FDA, CDC is giving recommendation based on the fourth dose for the third dose. But soon I'm sure you are going to get a second booster message also, and it will become a regular feature as we are taking the influenza vaccine every year, and we are going to take these boosters. Soon we will get all these recommendations. Thank you.
Correct. So I think there was also a study from Qatar which showed antibodies persisting till as long as 14 months after the vaccination or infection. So the time period for which it is existent is extremely variable. It can go from 6 months to up to even 14 months. So about the same vaccination, the booster dose, that would have been, one of my questions that Sir has already taken up. But do any of the other panelists want to add to something about, because in India, we still don't have a guideline about the second booster dose. And a lot of countries, like Sir said, Israel, I think even America is actually recommending a second booster dose. So anybody else wants to add anything to that?
I think both NHS and CDC have given recommendations for second booster for older people and people who have comorbidities. So that's what their recommendation is. And I think the US has also given some recommendation that people who have got the J&J, the Janssen vaccine can also get now the mRNA vaccine as their second booster. So that guideline also has changed a little bit in the US. Now, the interesting thing is that, I mean, in India, we still have not, I think, covered the entire population with the first booster, or as we call it, the precautionary dose. So I think which is why the guideline from India is still not coming, because they're still targeting to cover the first booster for the entire population.
Right.
And I think overall, compared to other, at least for the US, I think our cases are somehow, I think our mortality is also lesser, and our cases are also not as severe as compared to the US, is what my understanding is.
Yes, currently, I think, yes, ma'am, we're not reached that status. Plus, also, I think the subvariant now is much mild. I completely agree. But I also think that a lot of people are actually not even getting the first booster, because like we are reading in the newspapers every day that a lot of these vaccination doses are actually lying wasted in a lot of states. So I'm not sure if we do eventually get lines. I think especially for healthcare workers or people who are the first line, maybe it is high time, because it's already been over 6 months since we took our first booster or the precautionary dose. I think it's high time that we get our second booster, and that's again my personal opinion.
I think in India now the recent guideline has changed that you don't have to wait for 9 months. You can get it at 6 months, is what
Yes.
now India has recommended as their booster.
Yes. So, and since it's already been 6-7 months to all of us having taken our first booster, I think it is almost time that we start thinking of taking the second booster. So, and again, since ma'am, you were talking about the Johnson & Johnson vaccine in the US, what is your take on mixing of vaccines? Because, we hear a lot of people who are mixing, of course, vaccines. In the US, a lot of people who got their 2 shots here traveled to US once the, the travel restrictions were uplifted, and then they went there and got a Moderna vaccine or a Pfizer vaccine. So what is your take on mixing of these vaccines which is going on?
See, as far as the guidelines are concerned for India, we have to assume that we can only get the vaccine in India. Now, recently, they have given approval for using Corbevax as a booster, if you have taken either Covishield or Covaxin. And apparently, it is going to get implemented soon in the Coven app. So that option will be there for people who have not yet taken the booster. But as far as, I mean, we know that in our country, we don't have Pfizer and Moderna available, because the issue is about the storage. So it requires storage at much lower temperatures, which is an issue in India. But I think for people who have I know personally, I mean, I don't know about the data for people who have taken the Covishield vaccine and then gone and taken Pfizer vaccine, they have still gotten COVID. So also there is some data at this point in time that the Pfizer vaccine, because it is using the first strain of COVID, because it was the first vaccine that was released, is probably not as effective on Omicron as maybe our Indian vaccines. So that is also a matter of discussion. So as you said, that now Pfizer is looking into subtypes of vaccine for specific variants. Maybe in the future when that comes up, that could be an option to consider if you have that availability.
The clear message is any vaccine, homologous or heterologous, you have taken Covaxin or you have taken Covishield, and recently Carbovax also is there in the market now. You switch crossover with any vaccine, anything, it is going to increase your immunity. You are doing crossover with Moderna and Pfizer's, no issues. You cross Covaxin or Covishield with Covaxin. You cross Covaxin with the Carbovax. So it is a clear-cut study which has given specifically you switch over. They write any vaccine administered as a booster, immaterial of being homologous or heterologous, months after primary vaccination, by default increases the immune response to 95.3%. So absolutely the message to the masses is that you switch over to any vaccine with any vaccine. There is no confusion. It is going to help you. It may be homologous, it may be heterologous. It's going to help you. So don't worry, whatever is available after your primary vaccination, take it. It's going to help you.
There was some data, the data available about mixing Covaxin and Covishield, but I don't know why it is not approved yet to mix it as the booster. It is still, they've only approved Corbevax. So that is a strange thing.
It is all approved by ICMR. It is accepted fact now in the country. You use any, because one is you are using as a normal vaccination and you want to cross with, because maximum of us in the beginning have taken Covishield because it was freely available, and we switched it, crossed it over with Covaxin, and even the government has already given these instructions. Word over already, there's a beautiful article in New England Journal of Medicine, homologous or heterologous, use any, cross with any, it is going to increase your immunity.
But officially, you can still not register for a booster of the other vaccine, huh? Dr. Chawla, when you're trying to register, officially, they have unfortunately not yet made it. So even though there is enough data.
After Covishield, we took Covaxin, we have a certificate of Covaxin.
So वो आपका first dose होएगा ना, वो booster जैसे नहीं आएगा.
पता नहीं कैसे आएगा that side.
Officially नहीं है वो, unofficial.
It increases the immunity. No problem.
No, I also had COVID, my dear. So I did not take the fourth booster. As Shivani said, all of us have suffered.
Fourth booster is the COVID infection.
Correct.
But I actually have, luckily or unluckily, not even gotten the COVID infection. So I think I should at least take the second booster.
Yeah, you should take it.
So a few more questions left. Do antioxidants avert ARDS? I think we've already covered this. Utility of ROX index. Any insights? Dr. Prasanna wants to know from Bangalore. Anybody wants to answer this? Udnur sir, Chawla sir, utility of ROX index.
I don't know what is ROX.
I don't know ROX
Same here.
index.
Same here.
Really
So,
don't know.
Dr. Prasanna, extremely sorry. None of us are aware, but we will read about it and get back to you on this. Dr. Prasanna also wants to know, are both antiplatelets and anticoagulants same in a prothrombotic state? I think that Chawla sir has already discussed the role of ecosprin and the various other anticoagulants. So I think that is again covered.
Yeah.
Dr. Prakash from Gangtok wants to know how long steroids in severe cases of COVID with persistent GGOs. I think that's another question that we've covered. And then there is a wonderful compliment from my very dear friend and colleague, Dr. Jayaraman. Dr. Jayaraman is one person who always attends all the webinars and wonderful colleague. So Dr. Jayaraman compliments all of us on having a fantastic discussion, wonderful moderation, and very good panelists. So he thanks CCI. And with that, I would like to conclude the webinar. And
The role of convalescent plasma.
I think so. We discussed that it is already out of the guidelines, so there is no role anymore. But
Thank
if you want to add anything,
Nothing. There is no role of high titer. This thing, it is removed from the guidelines. I think what is not existing, we should forget.
yeah, because I think that was a long discussion. So, there were certain questions that we skipped because those were covered during the discussion. So I did not ask that question per se.
More authentic messages in this. I really enjoyed it. Thank you very much, Chawla sir. Thank you for moderating. Thank you.
Thank you, everybody.
Thank you, madam.
It was an absolute
Pratibha, madam.
honor and privilege for me to moderate such a.
Thank you, Shiva. You have done a very good job. Excellent moderation. Thank you, Pratibha ma'am. Thank you, Udnur. We may meet physically sometimes, Niranjan and
Thank you.
Thank you all. Thank you very much.
Thank you, everybody. It was an absolute honor and privilege for me to moderate such an esteemed panel. And I have actually learned a lot myself. And thank you, Chawla sir. Thank you, Pratibha ma'am. Thank you, Noor sir. Thank you, Bharate sir. And thank you, Dr. Niranjan. Absolutely wonderful debut on your behalf. And with that, I would also like to thank the entire team of CCI, especially Dr. Krishna, Dr. Vijay, Dr. Narayana Pradeep, Dr. Atri, Dr. Kirat, who, over time, every Thursday, they make sure that we have a flawless webinar experience with a new topic on every Thursday, and the excellent support provided by the Cipla technical team. Amitji, Vinodji, without you, we would never be able to pull off such a flawless show. So thank you, everybody. And with that, good night. Thanks a lot.
I want to thank
Bye, everybody.
And Narayanan. Well, Kirat, they are all Shivani, Kirat, they are always playback singers of this whole team. They are always there. And Atri, but front foot, well, Krishna Bhai, Vijay, Narayanan, I'm thankful to all of you and all three of my sisters who are active behind the scene. And with Atri, thank you very much. Thank you.
Thank you, sir. Good night, everybody.
Thank you.
Bye. Bye. Bye.
Thank you, ma'am. Bye.